Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 409 of our pharmacotherapy series, which majors in headache. This clinical case reads, KBG, a 27-year-old female financial analyst, presents to her general practitioner with a complaint of recurring headaches that worsened when she started her current job. Before this time, she had experienced infrequent headaches, which she associated with periods of stress. The headaches would occur 3 to 4 times yearly, were of a constant, dull, or pressing character, and were present around the entire head. Recently, headaches of similar character have been occurring about 1 to 2 times weekly, usually toward the end of her workday. The pain usually lasts the rest of the day but varies in intensity. Occasionally, a headache is present when she wakes up in the morning as well. KBG denies gastrointestinal and aura symptoms associated with her headaches. She has noticed that relaxation and alcohol ingestion seem to relieve these headaches, but aspirin and acetaminophen have been ineffective. Her blood pressure is 120 systolic, 74 diastolic. Her physical and neurologic examinations are completely normal. So my first question to you reads, what measures should be taken to relieve KBG's headaches? What is an appropriate goal for treatment? KBG appears to be suffering from frequent episodic tension-type headaches. She reports approximately 4 to 8 headache episodes per month, and these headaches have features that are stereotypical for tension-type headache. As in the treatment of other chronic headache disorders, a cure for recurrent tension-type headache is unlikely. KBG should clearly understand that the goal of treatment is a reduction in the frequency and severity of headache. Drug therapy and relaxation techniques are the primary means by which tension-type headaches are treated. Let's now discuss analgesics. Conventional analgesics, including non-steroidal anti-inflammatory drugs, are appropriate first-line treatments for tension headache. A recent meta-analysis of 4 controlled trials supported the effectiveness of both the combination product, acetaminophen, aspirin, and caffeine, and acetaminophen relative to placebo in achieving pain-free status at 2 hours post-administration for tension headache treatment. Secondary endpoints included pain-free status at 1 hour post, headache response at 2 hours, and level of impact on daily activity, with results being consistent with the primary outcome measure. A non-steroidal anti-inflammatory drug, e.g., ibuprofen or naproxen, would be an appropriate recommendation for the treatment of KBG's tension-type headaches because of her previous inadequate responses to aspirin and acetaminophen. KBG was prescribed ibuprofen 400 mg every 4 to 6 hours as needed for acute relief of recurrent tension-type headaches. At her next scheduled follow-up visit, KBG reported moderate relief with ibuprofen but complained of gastrointestinal upset with each dose, even when taken with food. My question to you reads: what prophylactic agents are available for continuous suppression of KBG's tension-type headaches? Next we will discuss prophylactic therapy. Prophylaxis is relevant in the context of both frequent, episodic tension headache and chronic tension headache. Amitriptyline has demonstrated efficacy in managing tension headache. A median daily dose of 75 mg yielded a significant improvement in headache index relative to placebo. Mirtazapine and venlafaxine have both demonstrated efficacy in tension headache treatment relative to placebo. Superiority for mirtazapine was demonstrated in measures of headache frequency, intensity, and duration for patients with prior treatment experience. Given KBG's increasing frequency of tension-type headache and her intolerance to moderate doses of ibuprofen, prophylactic treatment with amitriptyline would be appropriate. A starting dose of amitriptyline 10 mg nightly, increasing by 10 to 25 mg at 1-week intervals to a maintenance dose of 50 mg per day, should be prescribed, at which time headache response can be assessed and the dose increased or decreased as necessary. If effective, amitriptyline should be continued for 3 to 4 months before gradually decreasing the dose until the drug is completely discontinued. Therapy should be reinstituted if headaches return. Mirtazapine may be initiated as a second-line option for KBG, if amitriptyline is not effective. Let's now look at interprofessional management. Practices in the areas of spiritual meditation, cognitive therapy, and stress reduction and acupuncture have been assessed in headache management. A recent study, assessing outcome measures of headache frequency, severity, and medication use, as impacted by either spiritual meditation, secular meditation, i.e. internally and externally focused, or muscle relaxation, reported a favorable impact on episode frequency induced by spiritual meditation. A decrease in medication usage was similarly reflected in this cohort. However, neither pain sensitivity or severity differed. Interventions directed towards stress reduction, while deemed feasible, have not met statistical significance for changes in headache severity or frequency. Although stress reduction favorably impacted MIDAS and HIT-6 assessments relative to controls, the study lacked the statistical power to confer significance. Similarly, traditional acupuncture has yielded headache-associated pain relief. However, prospective trials are warranted to better elucidate the therapeutic impact of this practice. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arora, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video. which will be part 410.